Morning, everybody. Uh, First, I want to say, give a shout out to those of you who are having to deal with the LA fires. I know that they're quite extensive between Pacific Palisades and Pasadena now, the Eaton Canyon fire, and the one in the Palisades. For those of you who are out of your homes, we're thinking about you and hope that the day ends well. Good luck to all of you. Uh, the reason we're here is to introduce Maddie Jansen, who's going to be giving our colloquium today. Many of you know Dr. Jansen. She's a child fellow in the research track in child psychiatry. She did her undergraduate work in human biology at Stanford and then went on to her master's in public health and her MD as a DeBakey Scholar at the Tulane University in New Orleans. And that's quite an honor, the DeBakey Scholarship. She went on to a research track residency at Washington University in St. Louis, and that's really where she became interested in the role of racial disparities in access to mental health services and developed her specialization in community psychiatry. Since coming to UCLA for her fellowship, her child fellowship, she has been immersed really in research on multiracial youth. And by that, I mean kids who have more than two or more racial or ethnic backgrounds. You'll hear about her research on that in a moment. She's won numerous fellowships and grants, most recently from the American College of Psychiatry, the Laughlin Fellowship Award. She won an ACAP Pilot Award, a CHIPS Fellowship from NIMH, a Sorensen Foundation Research Fellow Award. And she also has a fairly extensive publication record with first authored papers in JCAP and Journal of Clinical Psychopharm and other journals as well. She makes a strong case in her research that multiracial youth, despite having some of the highest rates of mental illness in our country, have really been marginalized both in clinical services and in research. And this is really Maddie's passion, which is reducing this disparity through developing evidence-based interventions and culturally responsive care. So, what you'll be talking about today is multi-ethno-racial youth with mood disorders and substance use, culture, families, and research methodologies. Please welcome Dr. Maddie Jansen.
All right, give me 1 second to get this set up. All right, thank you, Dr. Mikowitz, for the introduction. Good morning, I'm Maddie Jansen, and I'm looking forward to sharing with you all a little bit about the landscape of mental health in a population that tends to be under-recognized and underserved. The population I'm referring to, of course, are youth with multiple ethnic or racial backgrounds, termed multi-ethno-racial youth. Specifically, I'm going to contextualize the origin of multiracial health disparities and discuss findings from 2 studies I've led since beginning my child psychiatry fellowship at UCLA 2.5 years ago. Please leave your questions in the Q&A section. We'll discuss them at the end of the talk. These are my disclosures. The studies I'll discuss in this talk have been graciously funded by these foundations, families, and the National Institute of Health. Otherwise, I have no financial disclosures. As we get started, here are our learning objectives: to understand the unique context underlying mental health disparities among multi-ethno-racial youth, to describe commonly experienced cultural factors impacting depression in this population, and to name important considerations for research methodology relevant to substance use. This is our agenda for today. First, I'll be presenting a bit about multi-ethno-racial youth, who they are, and why it's an important population to study. Then, I'll be discussing work from our multi-care study and the impact of culture on depressive symptoms. and we'll conclude by touching on preliminary results of our systematic review, which explores the influence of research methodology on alcohol use outcomes. Before we get started, I'd like to place this talk within the context of my own positionality, namely that my academic interest in multi-ethno-racial youth is informed by my own experiences as a multiracial person growing up here in the US. As a psychiatrist, I noticed a higher level of psychosocial complexity among my multiracial patients, and I learned that building trust often required increased time, validation, and dedicated efforts to ensure that they felt seen. It's my goal as a researcher to build a greater understanding of mental health concerns in this population in ways that enhance their clinical care, bolster resilience, and function to unlock their potential. I should note that during this talk, I'll be using the terms multiracial, multi-ethno-racial, and MER interchangeably. So, who are multi-ethno-racial youth, and why is it so critical that we seek to understand them better? The term multi-ethno-racial, or MER, refers to having two or more racial or ethnic backgrounds. In the US, recent estimates show that they make up about 10% of adults and 16.5% of youth. However, for reasons that we'll discuss later, this is likely an undercount. Due to evolving social norms, increasing diversity of childbearing partnerships, as well as decreased erasure and misclassification of MER populations, these youth are considered to be the fastest growing US ethno-racial group, with a 276% growth between the years 2010 and 2020. And in recent years, a number of studies have suggested that MER individuals experience a disproportionate burden of mental illness, often higher than other ethno-racial groups. Despite all of this, the mental health concerns of MER youth remain understudied, poorly understood, and under-recognized by clinicians and researchers alike. Fortunately, recent years have seen increased attention to MER mental health in the academic literature. Some studies, for example, indicate that when compared to monoracial peers, MER adults experience the highest burden of any mental illness, reaching prevalencies as high as 35%. Others have found that the highest rates of serious mental illness, depression, anxiety, and substance use to be among MER adults. Similar trends are seen among MER youth, with highest rates of depression, anxiety, substance use, suicidal ideation and behaviors, and disordered eating. So, why might it be that MER youth experience such high rates of mental illness? And why has this been under-recognized in the medical literature for so long? As you can imagine, the answers to these questions are complex. So we start off by discussing a very important framework, critical multiracial theory, or multi-crit. This framework serves to guide our understanding of the context in which multiracial youth develop. It says that racial categories in the US are based on a monoracial paradigm, an assumption that all members of society fit neatly into fixed racial and ethnic categories. This paradigm thus rejects the very existence of multiracial individuals and privileges those from single race backgrounds. Evidence of this paradigm is seen in the fact that anti-miscegenation laws outlawing interracial marriages were not overturned until 1967 by way of the Loving versus Virginia Supreme Court case. This court decision also outlawed the so-called one-drop rule, in which the principle of hypodescent was codified into law such that any person with a single African ancestor was considered to be of color. In fact, it was only in the year 2000 that the US Census allowed us to select more than one racial category. Before this, we would have to choose only one. The idea that multiracial individuals were prone to experiencing mental health challenges has long been a fixture in US consciousness. For example, the tragic mulatto was a commonly used literary archetype in the 19th and 20th centuries. This multiracial character was portrayed as depressed and suicidal due to the fact that they were rejected by both white communities and communities of color. Contemporarily, researchers have determined that MER individuals continue to experience a burden of racialized stressors. This includes societal erasure, rejection from monoracial communities of heritage, and identity invalidation. Many scholars believe that because MER individuals are chronically and uniquely exposed to a myriad of such stressors, that this is what underlies the elevated mental health risk. This phenomenon has been described as weathering, in which individuals constantly coping with racialized stressors experience detrimental health outcomes. Current research tells us that these cultural stressors unique to MER status do persist, and for multi-ethno-racial youth, if left unaddressed, have the potential to disrupt normative psychosocial development. For instance, studies show that it can be challenging for these kids to form their ethno-racial identities, which is, in a sense, a balancing act of negotiating conflicting familial influences, cultural heritage, and societal expectations. Furthermore, this is a process that often benefits from an intersectional lens, which, if not taught directly, and it rarely is, can be challenging for youth, especially in earlier stages of cognitive and social development. Further complicating this process, youth are tasked with managing highly complicated social challenges and at times discriminatory experiences. Retrospective qualitative studies of MER college students reveal high levels of peer rejection and social exclusion by monoracial communities of heritage. They were prone to experience multiracial identity invalidation and denial. They felt discriminated against by members of their own cultures for being a multiracial person, in addition to discrimination from the majority culture for being a person of color. They lacked a sense of community and were often one of the few multiracial kids in school. The family context has also been shown to be a source of stress for youth. For instance, because ethno-racial backgrounds of MER youth tend to differ from those of their parents, it can be challenging to support their children's psychosocial developmental needs. Also, parents may lack awareness of the challenges their children experience. They may also lack the language and knowledge to help their kids effectively organize and understand racialized experiences with peers and systems. And in some cases, youth may be subject to devaluing and discriminatory microaggressions perpetuated by their own family members. Now that we have a cursory understanding of the unique MER cultural context, I'll now present findings from our multi-care study in which we examine cultural factors impacting MER youth depression. So, what do we know about depression in MER individuals? Well, recent studies suggest that MER youth experience the highest rates of depression across all ethno-racial groups, with 27% experiencing a major depressive episode in the past year. We've also seen that certain MER cultural factors can impact depressive symptoms in adults. weak sense of multiracial identity, for example, is associated with elevations in depressive symptoms, while those with stronger multiracial identities show decreased depression and improved well-being. Perceived racial discrimination as well confers increased risk of depressive symptoms. Unfortunately, as of yet, little is known about the cultural underpinnings of depression among MER youth. Against this backdrop, we conducted an explorative study to begin clarifying the potential influence of culture on MER youth depression. Guided by the community-based participatory approach and in partnership with Healthy African American Families, we conducted 20 semi-structured qualitative interviews among MER youth and their caregivers. Youth participants were diverse in their MER backgrounds, and 60% carried formal psychiatric diagnosis. 40% of the sample had been diagnosed with depression, yet all reported having experienced depressive symptoms. We identified a number of risk factors for depressive symptoms rooted in the MER cultural context: low social connectedness, social exclusion, and weak sense of cultural identity were the most commonly reported. Our interviews revealed a number of key themes in which youth described how certain experiences may have contributed to their depressive symptoms. For example, youth often reported social exclusion and described a sense of being othered and feeling like an outsider due to their MER background. Youth felt that these experiences often led to worsened mood, hopelessness, guilty ruminations, and fatigue. As one participant so poignantly described, people always seem put off by the way I talk, dress, and behave because it doesn't really conform. It's exhausting. When I don't have the energy to deal with it, I self-isolate. This ends up making me feel more depressed. Youth also described protective factors which seem to lead to improvements in mood and depression. Most commonly reported were instances of high connectedness to peers, gaining knowledge about MER and personal cultural background, and having a strong sense of their multiracial identity. Participants noted that feeling connected to MER peers helped them to cope with depression. One participant stated, "Having people to relate to is the best medicine. It helps to make you feel like you're not the only one." This work has a number of important implications. Firstly, our results are the first to describe how MER cultural factors can and do influence manifestation of depressive symptoms among youth, contributing to both risk and resilience. Secondly, this work fills a critical gap in the literature and adds a layer of foundational support for further research involving larger nationally representative samples and quantitative methods. Lastly, the rich qualitative data we gathered has the potential to help guide future intervention development. This is of special importance due to the fact that there have yet to exist any evidence-based interventions for MER individuals. The remainder of this talk will talk briefly on preliminary findings from our systematic review, in which we examine the impact of differential research methods upon risky alcohol use among MER youth. As touched on earlier, there are notable methodologic complexities when it comes to studying MER populations. For example, epidemiologically, MER individuals tend to be unevenly dispersed geographically, and this can affect sampling and recruitment. Secondly, methods used to define MER status can and do vary across studies. This then can make it difficult to draw comparisons across studies using different methods. Accurate capture and classification of MER samples can also be affected by levels of MER acceptance, erasure, and discrimination in the social environments of participants. Some participants, for example, may not even be aware of the possibility of identifying with more than one ethno-racial background due to their upbringing and level of exposure to MER information. A third methodologic concern relates to analytic strategy and choice of covariates specific to substance use. This is because certain studies have suggested that multiracial families may be more likely to experience single-family households and family instability. Both of these factors are also known to confer increased risk of alcohol use disorder. Therefore, covarying by certain family-related confounders has the potential to impact study outcomes. Several recent studies indicate MER youth to be more likely than single-race peers to engage in risky alcohol use. However, little is known about how different study methods may be affecting these trends. Given the complexity of conducting research in MER populations, it's important to consider whether methodology in itself may be inaccurately portraying alcohol use risk in MER youth. I would like to note that this is not to invalidate the very real psychosocial stressors which may be contributing to risky alcohol use in MER youth. It is our goal to fully clarify and more deeply understand these trends in order to ensure that future clinical interventions may be developed in ways to appropriately and effectively address the problem at hand. Our study therefore aims to elucidate whether methodologic differences in study design can influence how MER youth compare to single-race peers in regard to problematic alcohol use behaviors. In order to do so, we have systematically reviewed all publications to date comparing rates of alcohol use in MER youth to single-race counterparts. In order to detect the presence of trends in the ways different study methods might impact study results, we carefully examined three factors: sample geography, operationalization of the MER identity, and choice of family-related covariates. Using search terms, which were in line with prior research, 146 articles were initially identified across 3 databases. After removing duplicates in articles not meeting inclusion and exclusion criteria, 8 articles were included for review. Across the 8 articles included, a total of 10 findings were identified, spanning 6 data sets, only 3 of which were nationally representative. Of note, 2 out of the 3 regional data sets were drawn from Seattle and had very small sample sizes ranging from N of 200 to 400. Importantly, all findings indicated MER youth to be at either highest or second highest risk of engaging in problematic alcohol use, which is notable unto itself. However, given the almost 50-50 distribution of first versus second highest risk, we were very interested to investigate whether or not certain methods in study design tended to favor one or the other. First, we looked at geography and found that nationally representative samples were more likely to indicate highest risk among MER youth than regional samples. Then, we looked at the way researchers assessed and defined MER status, finding a total of 3 methods. Although no clear trends emerged in whether certain methods seem to affect alcohol use risk, we did find that these methods seem to vary in inclusivity and that certain methods were used more often than others. For example, the least used but most inclusive method inquired about race through open-ended interview questions and allowed participants and their parents to answer in free response fashion, yet was used in only one study finding. The remaining 9 findings provided multiple choice answers and lacked the element of free response, either including multiracial as an answer choice or allowing for participants to select multiple races or ethnicities and then defining MER as those who selected 2 or more. The vast majority of studies employed the latter strategy. Lastly, we explored the potential impact of family-related covariates, finding that all 10 study findings were produced in the context of controlling for SEX by some proxy. Interestingly, our results also suggest that studies controlling for family structure were more likely to produce results with MER at first highest alcohol use risk compared to those who failed to do so. This suggests the potential of family structure to influence and potentially confound results in MER substance use research. Further studies and secondary analyses may be fruitful in clarifying this further. I'd like to highlight a few important take-home points that have been covered today, starting with the fact that multi-ethno-racial youth are a fast-growing yet high-risk population with regard to psychiatric illness. Cultural factors appear to confer elevated risk or protection against depressive symptoms among MER youth. And lastly, careful selection of study methods when conducting research on alcohol use in MER youth is likely indicated. As the results of our systematic review suggest, it is likely that study quality may be improved through use of nationally representative samples, open-ended inclusive inquiries on participant race or ethnicity, and use of family structure as a covariate in analyses. In closing, the complexity of multi-ethno-racial youth mental health needs remain an area of clinical significance and opportunity for discovery and research. MER lived experiences underscore the necessity of integrating intersectional perspectives into psychiatric research and practice. As mental health professionals, we're tasked with uncovering the mechanism through which identity, context, and systems influence mental health outcomes. This work demands precision, collaboration, and commitment to innovative approaches that are as nuanced as the populations we aim to serve. Thank you for taking part in this important conversation as we strive to build a world in which every young person feels seen and supported in their journey to well-being. I want to pause here before we open up for questions to express my gratitude to my mentors, Dr. Mikulec, Dr. Kataoka, and Dr. Graham. Without their support and profound expertise, these studies would not have been possible. I'd also like to thank my collaborators, research assistants, and UCLA's T32 program. Lastly, I thank our youth study participants who courageously shared their personal stories and experiences. Here are my references.
Yeah. Nice, very nicely done. Really interesting talk. I have a number of questions. We also have at least one in the Q&A. So why don't we just plow ahead? Maybe I could start by asking you to speak a little bit more about how these problems might lead to an intervention, given that we know that multiracial kids are at high risk for alcohol, substance abuse, mental illness. What can we do about it?
Great question. And that question is so important because number one, as we've seen today, this is a very, very high risk population. Um, and number two, there are there have been no interventions designed to date that address the unique needs and strengths of multi-ethno-racial youth. So this work is urgently needed. I think that when it comes to intervention design for youth, there are multiple points on their developmental trajectory where you could target their mental health needs. Um, for I do think that family-based approaches do hold the most promise given the complexities of the family structure and that there's a lot of space to improve communication, problem solving, and awareness in in the caregivers and youth themselves of what each other may be experiencing, and sort of joining on that topic. Uh, I also think that novel techniques are needed to ensure that access is equitable and um, and that practitioners are able to deliver these interventions without requiring intensive training. And I think that this may be accomplished through methods of digital mental health, as well as novel and innovative cultural tailoring techniques. I think that um, that would be where I would start.
I'm certainly not going to argue with you about families being important. I do wonder, though, why you wouldn't want to introduce a group, because so many of the kids seem to be saying they feel isolated and it would be great to have friends who are also multiracial. Why wouldn't you start with a support group?
I think that a support group needs to be a part of any intervention. So um, I would say that even in family-based interventions, if a group component could be included, that would also be highly effective. And that was actually something that we found in our study that um, many of the or a few of the participants were involved in these groups called um, like advocacy groups. I'm having trouble recalling the actual name. Affinity groups. That's what they were called, and they were involved in these affinity groups in their schools, in which kids were able to meet with each other from different ethno-racial backgrounds. And one participant said that they did not have a multiracial group at their school, and she didn't really feel comfortable joining the South Asian American group or the Latinx group. So she created this multiracial group and has felt that it's been such a support and just really like a safe space for these youth to explore and build understanding and relationships related to their culture.
A related question for me is, you showed that the data that suggested that when you co-vary family structure, then MER youth go to the top in terms of substance abuse. That would
Mhm.
suggest that there is something about the family structure of kids with MER, who are MER, that is correlated at least with substance abuse. What do you think that is?
It's a great question, and it's something that I've thought about a lot. Um, I think that there's a couple of things that may be playing a role here. Number one, um, for substance use in particular, and likely other mental illnesses as well, but I know that for substance use, single parent family households, that in itself can be a risk factor for substance use. And then some studies, and these are kind of old studies, so like we need to replicate them to actually see if this is true. But um, some studies have shown that multiracial families are have a higher likelihood of being single parent households. So that is one thing that could explain what we're seeing here. Um, and with regard to family structure in itself, um, I believe that measure that they used includes um, youth perception of the instability of their family. So it's also possible that um, youth may perceive their own families to feel unstable or unsupportive, um, um, which may be related to the fact that these families are operating in this monoracial paradigm of the US and um, really having to manage chronic racialized stress and um, and which can then impact the stability of the family unit.
Thank you. Now let's go to some of the Q&A here. You have here a question from Dr. Ito. Was there any sense that MER youth tended to favor or accentuate dominant racial identities, and whether this affected any outcomes, including self-perception or perceived discrimination, etc.?
That is such a great question, Dr. Ito. Um, we did not look into that specific question directly, but what I can say is that there has been research done showing that um, the context, like you're in the environmental context that you grow up in, can affect how you identify racially, and this also, there's no um, multiracial individuals are no exception to this. Um, in When it comes to like historically speaking, I think we talked about this a little bit earlier, but there was this notion of the one drop rule. So this kind of, this originated from this kind of like eugenics racial purity movement in which it was the opinion of white supremacy that we don't want any mixing. We want white people to be pure. And so there was pressure for individuals who had white background and, also heritage and other cultures to denounce their whiteness. Uh, there's also this phenomenon of passing in which, there are privileges. There were some societal privileges when individuals were able to pass as white, meaning that they were perceived by society as white. Um, so um, there's a lot of complexity there. And I do think that this is kind of an area that also we need to look into deeper to clarify, because it's a very fascinating and important topic.
We've got a question here from Dr. Suma Jacob. Great talk, Maddie. From a developmental lens, adolescence or pre-pubertal seem like an extra high risk period. Are there any studies of lifelong mental health outcomes? How do young adults or adults in their 30s such as data sets with autism, how do they compare to the general population mental health? It does make sense that increased early risk and severity of illness shifts those later trajectories also.
Thank you, Dr. Jacob. This is a wonderful question. So the research landscape of MER individuals is pretty sparse. And I've noticed that there is sort of a disconnect between those who have been doing studies in youth populations versus those doing research in adult populations. So I do not know of any studies that kind of examine this longitudinal risk profile, whether or not youth who, experience these mental health symptoms or risk factors early on in life, how they fare as they develop and move into their adulthood. I'm pretty up to date with the literature, so I don't know of any study that looks at that, but I think that it's really needed, especially because we need to understand if these problems are, if what happens during adolescence or childhood, if that, if those stressors or vulnerabilities do tend to persist, or if there's some sort of improvement in which say kids go to college and they interact with more multiracial peers and they develop a sense of community and they develop their language and ability to communicate and understand their experiences. It may be that this is the case for some individuals. So I think that studies that look into this are important to know about, to know about how this transpires, but also so that we can learn about how more well-adjusted multiracial individuals are coping with the situations better, and so that we can harness that knowledge and put it into an intervention to help those who are less able to cope, kind of meet that threshold.
Question from me, Bun. Is there evidence that are there evidences that indicate that current evidence-based practices such as PCIT or TFCBT are equally effective for MER youth?
I love this question because this is my next systematic review idea. I would love to know, how multiracial populations are faring in these interventions and these evidence-based interventions. If they're experiencing higher levels of dropout, if they feel like therapeutic alliance was an issue for them. And I think that that's a very, very important next step in this field of research. What I can tell you in kind of like the studies that I've reviewed thus far is that, studies that include multiracial individuals, may not be powered to sufficiently analyze this group specifically. And I don't think that's because there are not enough multiracial individuals in their study. I think that there are issues in terms of accurately capturing the races of participants. So, for instance, using an open-ended free response techniques in which the researcher kind of asks in an empathetic way, potentially with more than one question, for the participants to describe their racial background. What I found in in my own research is that, especially the younger the kids are, the more they need prompting when it comes to answering these questions. Because if they don't understand something, or if they don't feel safe, or if they don't have the language, which many of them do not, it can be really hard for them to describe their racial background. So that can lead to inaccurate capture of this population. And so I think that moving forward, it will be very important that um, researchers, pay special attention to the ways that they're categorizing, operationalizing, and mining their data with regard to race.
I think that's all three questions. Let me ask one more, unless anybody wants to put any more questions in the Q&A. We do have a few more minutes. Uh, Imagine the case where you have a multiracial youth. I don't know, maybe one parent is African American, the other one is white, and one of those parents disappears. There's a divorce, or the parent moves away, or doesn't want to be involved in the kid. How does that affect racial identity? Have you run across cases like that, or descriptions of that, where the family structure ends up playing such a big role?
I have run across many instances of this, and this is something that is not yet been explored, um, systematically in the literature. And I think that this is also something we need to be looking at and trying to build our understanding of. But what I've seen, kind of just like in patients that I've cared for, are that there's a variable experience. And so losing a parent is a traumatic thing, regardless of whether you're multiracial or not. But parents are considered to be the primary socializing agents when it comes to racial identity development. And so having a parent who is no longer present, or having a parent who um, you know doesn't like to talk about race, doesn't want to talk about race, that can really impact the child's ability to explore and try on different identities, and really work towards building a concept of their own racial identity. It's a process of trial and error, and there's a lot of really good research about racial identity development and monoracial youth, and much of that work does seem to apply to some degree to multiracial youth. It's just sort of that multiracial youth have this added layer of complexity of negotiating multiple cultures, as well as the aspect of multiraciality, which doesn't tend to be as accepted by society as a whole. So it's it's I guess to answer your question, um, yeah, I think it can vary, but I would say that the best case scenario is to have two parents who are um, really good about communicating about race and culture, who invite their children to have discussions um, about those aspects, and sort of create a safe and non-judgmental space for kids to really you know feel free to be themselves, feel free of judgment, feel free of discrimination, obviously. That's a big one. And I think that, that's kind of the best case scenario when it comes to racial identity development.
You want to say anything else about the K Award you're going to be applying for?
Well, I am planning to apply for a K Award this upcoming year. Um, and the focus of my project will be to design a novel intervention that uses sort of innovative techniques to create a culturally appropriate intervention for youth with co-occurring depressive and substance use symptoms. We have been thinking deeply about how to make sure that this intervention has a precision medicine approach in that it meets the distinct and individualized needs of each individual youth participant. And the importance of that is like, obviously this is it's a good thing to deliver personalized and precision medicine, but for multiracial youth in particular, this is especially important. So that's kind of what is on the horizon, and I'm so excited to continue working in this space.
Very good. It looks like we might have one more question here. Oh, Mary O'Connor, could you speak to the strengths of being multiracial?
I love this question so much. So I didn't present kind of our data, in which we collected youth perceptions of the strengths of being multiracial, but there are so many, and being multiracial in itself is not the issue. It's kind of society that has created these stressors and difficulties. So I think number one, something that kids were mentioning is the fact that they perceive themselves to be sort of more accepting of differences in culture and interested in learning about the backgrounds and experiences of other people. They felt like they were more likely to approach their peers in non-judgmental ways, and be very tolerant of differences. And this is even in middle school kids who, as we know, sameness and blending in is the goal. They also felt like the fact that they had multiple cultures was beneficial in itself. So one participant mentioned that it is such a, this was the mother, she mentioned, like, it is such a gift that my child is multiracial. It's because they have such a rich cultural background and so much energy and values and sort of coping mechanisms to draw from. So I thought that this was really beautiful and very true.
Okay, I think we're at time. Thank you very much, Dr. Jensen, for that talk and for kind of raising our consciousness about these issues, about not thinking about single race, but multiple races and multiple ethnicities and how kids like that might need their own unique intervention. I'm looking forward to working with you on this K award, and appreciate your thoughtfulness. So thank you, and thank you, everybody, and be safe out there. Bye-bye.